Tearing is an annoying and embarrassing pathology which is an increasingly popular reason for arranging a consultation. There are many etiologies with patients often presenting narrowed or obstructed lacrimal ducts. Bicanalicular, monocanalicular and mini-Minoka intubation devices have been available for many years and offer proven efficacy. These devices still offer excellent therapy for our patients. However, their insertion requires certain expertise and has to be performed in the operating room with the patient under local or general anesthesia. These drawbacks prompted our development of an autostable bicanaliculus intubation set that can be used easily by any ophthalmologist and which can be fitted in the practitioner's consulting rooms, requiring simply anesthetic eye drops. The autostable bicanaliculus intubation set 2 is assembled ready for use on 2 metal guides for easier guidance during insertion. The standard version of the intubation is 30 mm long and consists of a silicone tube 0.64 mm in diameter. A central mark ensures that the intubation position is correct during insertion. At the end of each, there is an anchor consisting of 2 flexible winglets which fold in during insertion. This maintains the overall size at the diameter of the silicone tube. These winglets unfold once the intubation has passed the junction of the canaliculi and the lacrimal sac. The autostable bicanaliculus intubation set 2 can treat pathology of the horizontal lacrimal duct, and more particularly punctual artesia and the canalicular stricture. More generally, it is indicated for certain conditions treated by bicanaliculo-nasal intubation, BCNI, such as infectious and traumatic canalicular pathologies. The intubation comes with a 1 mm dilator for optimum dilatation. A Bowman graduated metal probe is used to check the canalicular permeability and, if necessary, to determine the length of the intubation. Simple monofilament forceps are useful when inserting the device. In the consulting room, the procedure is performed using a slit lamp or an examination table using a magnification system after instilling anesthetic eye drops. Start by gently dilating the superior and inferior meatusses. Using the size dilator provided ensures that sufficient dilation is achieved prior to the intubation insertion. Check the permeability of the canaliculi by gently probing to obtain contact with the bone. The 2 marks on the metal probe indicate whether the choice of intubation is correct. We recommend, however, using the 30 mm autostable bicanaliculus intubation set 2 as the intubation set of choice, since it is the most suitable in the majority of cases. Ask the patient to look down as you pull gently on the eyelid. Intubation insertion begins with the superior meatus, inserting beyond the mark to ensure that the winglets have unfolded after passing the junction of the canaliculi and the lacrimal sac. We recommend holding the intubation using monofilament forceps when removing the guide. The intubation insertion into the inferior meatus is identical. When inserting, ensure that the vertical travel along the duct, during which the winglets remain folded, is followed by guiding the intubation horizontally by pulling on the eyelid. To simplify the correct positioning of the intubation, we gently massage the lacrimal sac and the point when the meatusses meet, after first asking the patient to close their eyes. After fitting the device, check that the mark is centered between the 2 meatusses and that the intubation can be moved, This confirms that the intubation has been positioned correctly. Some practitioners prefer to use the slit lamp due to its ease of use and its presence in the consulting room. The technique is the same, with insertion via the superior meatus and then via the inferior meatus. This technique may offer a better view of the position of the central mark. Because of the rapidity of the insertion and the fact that it is virtually pain-free, patients have no idea of the importance of the procedure they have just experienced. It is very important that post-fitting recommendations are followed. Prescribe a steroidal antibiotic for 1 week, followed by a simple disinfectant that is used until the removal of the intubation, normally between 1 and 3 months later. The patients are followed up after 1 week and then every month. We tell our patients that they may experience ocular irritation for a few days after the insertion. We advise them to avoid pulling on their eyelids when instilling the eye drops, not to touch their eyes, and to wear a patch or a dressing for the first few nights. We believe that using the autostable bicanaliculus intubation set 2 to treat tearing is attractive for the ophthalmologist, as it is simple to insert and appealing for patients, and since it can be fitted in the consulting room.